As you know, schizophrenia starts in pre-birth. There's an increased neuroinflammation and decreased neuroplasticity and neurochemical problems accompany it. And it's a progressive and disrupting, harming disorder. So what are we with this disorder? Actually, we're in the part where already the disease has set on. So actually, the most beneficial part is a pre-tomal and term would be the most important part. And actually, of course, prodromal would be the limited what we could do during this term. We cannot do much. So when the neurodegeneration, the decreased neuroplasticity cannot be hindered what we could do for the patient. However, when the patient comes to us, the first years, the prodromal term at a point is the term when we can help the patient more. Why we cannot help more? Because we give low dose drug and they can respond to these drugs. However, during this time there are many high side effects. However, this is like opportunity window. So they respond to antipsychotics within the 2 or 50 year of after the first episode. However, just in reverse, during this time, if we cannot, if the patient does not, and there is this time when the treatment is not responded, and this is the time it causes the psychosis, and this is time when the hospitalization and relapse is seen and suicidal risk is seen, and this is the time there is a great loss of cells in the brain. If the required measures would not be taken, then this could be a time for harming. So every attack actually causes 10 to 12 neuroptic synapse cells are lost, and this is the news for the resistance, of course. And very highly during this time, the relapse rates and negativities. So we see that almost 50% of them there is a relapse. And one of the most important reasons is that in compliance to the treatment, it is actually can be controlled. And non-compliance to the treatment increases the relapse by 5 folds. So as a result, what we come across with in the first attack psychosis, the treatment success is very high, and symptomatic remission is 52%, and the improvement is 20%. And improvement is discussable, of course. I'm within psychiatry for 32 years, but I have to admit that I haven't seen so far a schizophrenia patient so far. There is remission, but I don't know whether there's recovery, full recovery. And for the first attack psychosis, there are positive results, and symptomatic remission is 52% and improvement is 20%. And during this term, the what the significance determines the improvement is the treatment, the term, which there is no treatment. So we can talk about that response to treatment and the term without any treatment, having it short. This is in relation, in proportion with this recovery or improvement. However, as the case increases in the upcoming progression, what we see that the improvement goes or recovery decreases to 3% in the progression. And one of the most important reason for that is that relapses, and the relapses are caused by the non-compliance to the treatment. So for that reason, when there is non-compliance to the treatment, or the patient who responds to antipsychotics, psychotics, they do not respond to anymore, and we have less options of treatment, and there is a need to use higher dose of antipsychotics, and this is important. How precise it is. There are also people who argue the opposite, and the classical antipsychotics are neurotoxic actually, and the new antipsychotics maybe with high dose they are neurotoxic, and since we need to increase the doses, the neuron sparing drugs actually in hand become neurotoxic as well. So, and of course there's need for combination of the drugs and more hospitalization, and there would be more loss in the brain. So every attack causes 10 cc of brain, so resistance to treatments, so on and so forth. So there are many negativities come out, and after we have the relapse, and this is, we see that there comes along a non-compliance to the treatment. So in the early time, the greatest task of us is to keep the patient in treatment. So actually there is a motto that we can produce, the right drug in the right time. This would certainly decrease and hinder the non-compliance to the treatment. This would facilitate our work. It is the right drug in the right time. So right time, right drug, which one is it? Actually, as I mentioned before, before the patient says, I am sick, in the prodromal period, we could do something. But if we cannot do something, we say that let the patient to fall into the worst position so that we can help. Anyhow, what we can do in the prodromal phase. Of course, long-term antipsychotics could be helpful. They have effect to be protecting from relapse. So what happens is that this is not a miracle, of course. At a certain level, it may resolve the problem. This is a good study. It's the same preparation in the oral form, and it decreases the relapse rates, and we see that they have a long term increase in the treatment recovery. It's related to the fluctasen intake. So it might be the case that the patient would not be within the range of taking the drugs within a certain range. So for that reason, long-term antipsychotics in the fields of functional recovery, it provides better results. In this study, it's interesting. Relapse could be preventive. In our practice, we come across with this very much. So he didn't uh, benefit from A, B. So many relapses have emerged. So as a result, what should we do? We should give a long term. So the patients using the long term in their prognostic, these are related to prognostic factors. And actually what happens is that the physicians actually try each drug that is introduced into the market new. As a result, in the patients with negative prognostic factors, we see that there is a decrease in the relapses and the functional recovery is better. There are data related to these. While we have the data like was Nasrallah has an mix and rejection, and I think that he's jealous about the cardiologist. And when a myocardial infarction a patient has, they do everything in order to hinder the second one. So do you think that the brain cells are less important? So why we should not act like the cardiologists? Why do we wait the patient to have a second attack? And then we cause the patients to lose neurons in the brain. So he has such a rejection, and I think he's right as well. Why do we wait for this? Okay, he had an attack. There is non-compliance to the treatment. Okay, let him or her have another attack. Okay, one would not make a problem. Or second one, okay, now let's start with the second time, the long term. But the neurons and synapses are lost within this time. But if the if you would if it was started earlier, then it would be better. What are the studies show? The chronic time period studies show if there is a long-term antipsychotic, and this is a preventive in early relapse, and early relapse means as having a relapse within 1 year of time, and it is long-term antipsychotic is important. So there is a 30,000 cases. It shows that it is very valuable. And Mr. Köksal mentioned that we cannot do it. And in the second year, they're lost. The patients are lost. But however, in the other countries, they do this. So we see that something is not right in our country. Clozapine and long-term antipsychotics are really preventive, and they are preventing in the hospital stays as well. And there is also an interesting thing. We see that the same drug, so there are differences between the oral form as well as the long-term acting ones. So it is not about the molecule itself, but the form is also important binding as well, or it's also a determiner. It's determining. And another study here is that, of course, the most important thing is to survive. And related to mortality, clozapine use and long-term use drugs, we see that they are more helpful. This is not an advertisement, but what the studies say. This is what it said. This slide is interesting here. What prevents people from relapse? The long-term psychosocial life and approaches are preventive. Being young is also preventive, but incompliance or non-compliance to the treatment is causes the relapse, and substance use also causes the relapse, and comorbidities, other comorbidities are the most important thing for the relapse. So non-compliance to treatment, what happens is that So long-term antipsychotics, this is in our hand actually. And I hope that those great drugs mentioned by Ms. Feza would be in use soon. Then we shall be talking about more good things. And what are the other advantages of these long-term ones? There was a patient I was following. His name was Ahmet, and Ahmet never missed any of his appointment with me. That's good. But every time there was a problem every time when he came to me related to the treatment. He didn't miss any appointment, but there was always a problem. And he was wondering what if I decrease the dose. And then in the other one, I increased the doses, and then he was wondering, and then the one, I stopped using the drug. And another one. So the ones know that there were the uh, there were the small booklets where the prescriptions were made, and Ahmed was picking out all of these because somebody would reach to this and would understand that I have the sickness. I tell this. So when I considered you prescribe long term, and I was asking, he was asking, whom I'm going to take these drugs from me because they would understand that I am a long term patient. So actually, it's about a good compliance. So for that reason, because of other reasons, it is that preventing the non-compliance, it causes less hospitalization, and also it is not that the patient is not non-compliant but does not accept to use the drug, take the drug. And related to the negative part, there's also a story by Ahmed. He was afraid of stigmatization. So since I'm not able to do this myself, then the other people would certainly stigmatize me. So the reason for this is that in the place where I live, I'm an craftsman. If they understand that I have the sickness, nobody would come to me, would have dialogue with me. And of course, there is such a situation that we come across, and we do not have much information regarding the rest. And of course, the risk, suicidal risk, when they take their drugs, they have less risk of for suicide. So we have the pros and cons accordingly. So what do the holy guides say about these guides? As I mentioned just a while ago,
bulunduğum
I was complaining about that. So what they are saying that almost of them, let's assume that there is a non-compliance, non-adherence, or let's say that there is a relapse, and after that we shall see. So I don't think that this is something nice, because the guideline says that there will be non-compliance and relapses. So what this means that we have to deal with that. And some of the people says that the preference of the patients is important. In such cases, it may be used. So what about the indications? We have the first line, uh, long-lasting antipsychotic. We have the schizophrenia, delusional disorder, and schizoaffective disorder. The second line treatment, again, we have schizophrenia, delusional disorder, schizoaffective disorder, bipolar disorder, and personality disorder. So here we have the use of guidelines according to the period of the illness. For the schizophrenia, It may be tried, but it's not recommended for bipolar disorder, and it can be the second line can be introduced from the first recurrent psychotic episode. So, indications of delays according to the clinical characteristics. If there is a relapse, if there is a no adherence, if there is a hazard risk for others and for themselves, if there is low insight, if there is patient preference, and if there is a positive depot experience during the first line for schizophrenia, and also the second line, medicines can be used. If there is the cognitive deficits and social isolations, it can be used. And in case of bipolar disorder, if there is non-adherence, if there is a positive experience, and if there is the patient preference, it can be used. And on the second line, if we have positive symptoms, it can be used. But if there are negative symptoms and suicidal risks, only the second line long acting can be used. And for the bipolar disorder, it can be used for the manic polarity for the rapid cycling on the second line. So the long-lasting antipsychotics can be used. So what are the factors to be taken into consideration in selecting an LAA? Can we say that, or are there other criteria to be taken into consideration? Of course there are. So what are those criteria? So we have some patient-related factors and the positive response of the patients to the antipsychotics. We can opt for that again. And if the patient has a positive previous response to the oral antipsychotic, we can go with that too. But we need to look into the adverse effects like akathisia or sexual dysfunctions, because especially when it comes to the sexual dysfunction, the non-adherence of the patient is one of the most important reasons. So if you are remembering the patient, the reason for discontinuing the treatment, you would be enforcing that. And akathisia is like a super important issue, especially with the longer acting medicines. So maybe sometimes it's not meaningful to use that. And the system lead factors, out-of-the-pocket expenses for the patient, because, as you know, those drugs are expensive. So I was talking with the patient, and they were like, if I would have that much money, I wouldn't become ill, indeed, they said. And of course, formulary or insurance restrictions, those are the kind of factors that we should take into consideration. And also the clinician personal experience using a specific LAI, the risk and the benefit balance, that those should be taken into consideration too. And long acting medications like 1 week, 1 month, or 3 months, or biannually formulations. There is like a quite a ample variety of the formulations. And also if we need an oral contribution or not. And also the cold chain system, the availability of the system, it is also important, because whenever we are talking about the cold chain, the patients are like, okay, I need to put my medication in refrigerator, in the deep freezer. But what we mean by the cold chain is a temperature between like 4 to 12 Celsius degrees. It's not that that they are going to put their medications in the deep freezer. So it should be discussed if the cold chain should be used or not. So, in summary, the efficacy of the antipsychotics in the early and also in the chronic period is similar. But what was our motto? We need the adequate medicine during the appropriate times. And also, we need the medication which may prevent the relapse. This is the major clinical goal in the treatment, because we are talking about the frequency of the relapse and a very negative prognosis. So this is our major clinical goal. And currently, we have the LAIs for now, until we will discover the new ones. Thank you very much, Professor, for your speech and for your presentation.